Hello, my name is Alexa Lopez. I'm a student physical therapist, and today I'm going to be giving you some educational tutorials on the range of motion of dorsiflexion. So, with this motion, this is in the sagittal plane, and we have different muscles that contribute to it. So the first one is the tibialis anterior. This muscle does inversion and it also does dorsiflexion. And the next muscle that we have is your extensor digitorum longus. This muscle brings your foot into dorsiflexion and everts the foot as well. We have the extensor hallucis longus. This muscle also dorsiflexes and inverts. And the last one that we have is our peroneus tertius. This muscle dorsiflexes and everts the foot. All of those muscles are going to be innervated by your deep fibular nerve. So if there is an injury to that nerve, dorsiflexion would be completely gone. So this is going to be easily seen when you do gait analysis. It's going to be called drop foot when you see the patient that has that nerve injury. So with the patient in this position, I'm going to go ahead and show you first passive range of motion for dorsiflexion. So I have the patient supine, and I have my stabilizing arm on the distal tibiofibular joint, and I have my movement arm. My force arm is going to be around the calcaneus, and the patient's foot is going to be on top of my forearm. So what I'm going to go ahead and do, my positioning is in this lunge position, and I'm just going to go ahead and move my body weight forward, getting to this end point of the patient's motion, and then go ahead and come right back down. And I'll go ahead and come back up to the end range, and then come right back down. And you would want to do this for about 12 to 15 reps, and you could complete this with 2 to 3 sets. And with somebody that's trying to have stiffness eliminated, you would want to have this done 2 times a week frequencies. Or if this is for somebody that is post-op, this is something that you may want to do with them initially as opposed to active range of motion, or if they actually have a contraindication for active range of motion, then passive range of motion would be what you would essentially want to use first. Now I'm going to show you stretching for dorsiflexion. The patient is supine and their leg is in full extension with their knee. You can also do this with the knee in flexion. You will be able to achieve more range of motion for dorsiflexion because it's cutting off that gastroc from inhibiting that range of motion. But just for this video and for this education purposes, I'm going to go ahead and show you the stretching technique passively with the knee fully extended. So with my stabilizing arm, it's just going to be around the anterior part of that tibia. And I'm going to have my movement on my force arm around that calcaneus, and their foot is going to be comfortably around my forearm. So with this, I'm going to move my body weight and shift it forward from this lunge position. And I'm just going to go ahead and try and get to that end range that's comfortable for the patient. And then we will just hold this. I could also include some contract, relax techniques. So with that, I would have the patient fully dorsiflex their foot, and I could have them relax afterwards. So with this, I will have the patient go ahead and please push against my hand as if you were pushing on a gas pedal. Good, good, good. Push, push all the way down to that range of motion, all the way down, and completely relax. And then I will go ahead and hold for about 30 to 60 seconds, depending on what your patient needs, depending on how tight the muscle is or the Achilles, how much stiffness is going on. We would do this for around 2 to 3 different sets, and if this is for a patient that is for muscle stiffness related, I would want to do this around 2 times per week. And then we would go ahead and relax. Next, we're going to do some joint mobilizations to improve dorsiflexion. So I'm going to be mobilizing the talus over the tibia, so I'm going to have to do a posterior translation. I'll have the patient supine with his knee fully extended and his ankle off the table. So if the patient was coming in for pain, I will want to do my grades 1 and 2, or I can do a sustained grade 1 and 2 as well. If they're coming in for stiffness relation, I will want to do a grade 3 to 4 oscillations, and I can also do a sustained grade 3. So let me go ahead and show you what those look like. My stabilizing arm is going to be over the anterior part of the tibia. I'm going to be in a lunge position so that I can really have a good force generator with my force arm. So with that, I'm going to use my web of my hand over the talus, aligning my points so that I'm creating a good force motion. So with this, I'm going to go ahead and I'm going to actually ask you, can you go off, slide your body onto the table a little bit more? More onto the table? Good. So from here, I'm going to go ahead and have them first in this open packed position. And I'm going to go ahead and start with a grade 1. And we know this is just going to be a very small amplitude. And again, with these, I will want to do it for about 2 to 3 oscillations per second. And I will do it for about a minute in duration. So grade 1, small oscillation, small amplitude. Grade 2, increasing that amplitude. Grade 3, I'm actually going to get to that end range and pushing the oscillations all the way to that end range and coming back. And then for my grade 4, I'm going to hold to that end range and do those quick oscillations. If I wanted to do that sustained at any point, I know that I can just go and pull that distraction very, very slightly for that grade 1 and hold. And I can hold this again for about that 30 seconds to a minute. If I want to do that grade 2, I do a greater distraction, and then I kind of pull that motion a little bit greater in amplitude. And then that grade 3 will be to that full end range past to get to that stretch. And usually for patients, I would recommend, if you were doing these, you would want to do it about 2 times per week. So now for the resistive exercise component for dorsiflexion, I will have the patient seated and their legs elevated above the ground. Using a dumbbell is really good for dorsiflexion because with this exercise, you're using both feet at the same time bilaterally. So this is going to save time as opposed to using TheraBands single, which isn't bad, but it just takes a little bit more time with 12 to 15 reps, 2 to 3 sets. So with this, I can do more exercises with the patient or maybe possibly do some manual therapy that day with them. So I will have the dumbbell in between both feet. Have them hold the dumbbell together using their muscles. I'm going to have them relax their knees, making sure it's in that 90 degrees, and allow the dumbbell to push their feet down, all the way down, all the way down. And then I want them to use their muscles and go ahead and dorsiflex their foot. So point your toes all the way up. Good. And then go ahead and go all the way down, let the dumbbell pull you down. So again, bring your toes all the way up. Good. And go ahead and bring your toes all the way down. You can adjust the dumbbell. Here you go. And this is good so you can monitor and see if the dumbbell's too heavy. You can adjust that. Is it too light? See if there's any compensations going on. Ask the patient if there's any discomfort or any pain. You can monitor if there's any shaking. Usually I would want the patient to do about 12 to 15 reps, 2 to 3 sets. High reps because these are more endurance muscles, not so much power muscles, so you want more reps. Very good. And you would give a good rest in between sets as well.